Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse focused in the area of hospice and palliative care. I'm also a certified end-of-life doula through the International Doula Life Movement, a writer and a book author. If you're new to this channel, welcome. Thank you for taking the time to be here. In this channel, we talk about issues related to death and dying. After all, we are all going to die. Shouldn't we be aware of what we're heading to, of what's coming before us? The topic for today's video is for new hospice nurses, as well as those who may have been in the field, but may feel they need to rely on things other than their intuition. We want to talk about the nursing gut, the nursing intuition. And before we go into today's topic, I want to take a moment and do what I've been trying to encourage all my listeners and viewers to be involved in, is building resilience. It is beyond common in the end-of-life field, whether as a hospice nurse or a doula, to have somebody tell you, you must be special to work here. It takes a calling, and while I do believe it is a calling, I'm not trying to argue against those who believe it's a career or a profession. It is, but it is a special place. But like, how do you work with death day in and day out without uh, just being pulled down into the darkness, so to speak? And to me, it's building resilience. To me, there are three pillars of resilience. We work on the third pillar here. For those that are interested, I'll briefly go over the other two. For me, pillar one is my faith in Christ Jesus. Pillar two is forgiveness. And pillar three is gratitude. What are you grateful for? So as I ask myself, what am I grateful for? I'm grateful for my wife who puts up with my autism, my panic attacks, uh, my abnormalities. I'm a very broken person, um, weird, hopefully in a good sense. I'm grateful to the people I interact with. I had a lady that works in a funeral collective trying to uh, educate people on end-of-life doulas and how important we are. And she shared with me one of the articles they had on their blog was asking if I could be a guest writer for them. I read the article. It was very compelling, very well done, with one minor exception. It used the word accreditation as if it was giving the illusion that schools are accredited, and they're not. And thankfully, she did take my input and went back and revised the article. But it was because of her input, I actually wrote an article dealing with advanced directives that's being published on Compassion Crossing on, I believe it's Monday, Monday, September 1st is going to be the article on compassioncrossing.info that life happens. There's no master plan in terms of you being aware. Like, I'm an obsessive compulsive planner. You don't know if you're going to be in a car accident, a heart attack, or anything else going on. So it's better to have an advanced, a complete living will and have that with you and up to date. And as we talk about that subject matter, I've been preparing for my first meeting. I did a free will clinic. This is part of the gratitude. I did a free will clinic on Monday, August 18th, where I think it was 6 or 7 lawyers, maybe it was 8, around there, did 33 wills. I don't know if that number sounds high or low, but these take time. Some of these lawyers were with these individuals for an hour, 2 hours or more, really crafting to their last will and testament what their desires were for free. And lawyers were directing people to me as an end-of-life doula who could do living wills. I didn't talk to all 33. Some of them were there for that free will, and good for them. But they had busy lives, and maybe their will event went longer than they were thinking, and they didn't have time. But I did have a small handful come over, and I do have an appointment with one person, which is to be, I shared in a previous video, the experience was a blessing enough that if there were zero, I still would have been happy and glad that I did it. But advanced directives, and I know rabbit trail, there's a lot to it. It's not just pulling the plug. And you should be using state forms. So here in Kentucky, we have this. This is through AARP that leads you through caring info. So we have this, but we also have through a former attorney general, but this is very popular in the hospitals. We have this. And I want to do a caution moment. If you're saying, I'm going to go and write my own one, I know how to use Word or Google Docs, you're in danger, danger, danger land. More and more places are looking for state documents. So if your state has a specific document, use the document. If the state does it, look for what else is crafted and then get it notarized and witnessed, where the witnesses are not relatives, they're not the doula, they're complete strangers to the case, but witnessing the signatures and the notary is not the doula. But there's dementia directives. More on dementia directives. There's mental health directives. The mental health directives, by the way, goes in what antipsychotic medications are you refusing? And I'm not a fan of having to explain why, because rights are to stop. There's also through WashingtonLawHelp.org, the SED. Now, the actual directives are small. This was like a 16-page document, 8 pages double-sided. But what was when I saw this, it was like, wow, there's an area for disputes. There's an area on here. There's a critical, Michelle, one of my classmates, uh, she's a fellow hospice nurse, but her background is in psychiatry. She was like, very like, we need liability waivers. So that's a huge thing. And then there are state, power of attorney. And I don't want to go too much further because I don't want to get too far down this rabbit trail. But there's a lot that goes into a living will beyond, I'm going to just pull the plug. So I'm grateful for that. I'm grateful for Helen, who reached out to me from Ohio. She's traveling. She lives and works in Berea. But she says, I have a potential client from you. This is from interacting with business networking and going to that will event. I have a potential client for you. They're a veteran and they're young and they're healthy, but they want to make sure that when they can't speak for themselves, that their wishes are met. And that's why it's so, so critically important. I'm grateful for Helen. I'm grateful for all of you who are buying and reading my books and supporting me on this very small channel. So let's get to today's topic. Again, mainly for new hospice nurses, but I also want to say that if you're an experienced hospice nurse, don't run away from this video. I value your time. And by the way, for anyone who hasn't already, please consider subscribing, the bell notification, and liking. The reason I don't want my older hospice, when I say older, I'm talking experience, not necessarily age, running away from this video is I did, when I say talk, I'm talking electronically in this perspective to a hospice for 20 years hospice nursing, and they were sharing with me, they were taught to go by the numbers. Internally, I'm hoping with you, my viewers, I can be a little bit more transparent and not, let me just turn off the thing that keeps on beeping on my watch and on the phone. But I'm hoping I could be a little bit more vulnerable with you where I would say to act differently if I'm in certain settings, always with truth and integrity, but I don't always share I don't do a mind dump, so to speak. Please pardon me, allergy season here in Kentucky. So, but we should not in hospice, and this is new nurses, please pay attention to this. A lot of new nurses, you're coming from the ER, there's nurses coming from labor and delivery. Anyone who is an LPN or an RN, RNs are typically more in demand, are needed in hospice. LPNs and RNs, it does not matter your background, are needed in hospice. But a lot of people, especially if they're coming from the hospital setting or nursing home setting or home health care setting, are trained to rescue. They're trained to treat abnormal numbers. They're trained to look, oh, if I'm seeing this, I need to request these labs and look at these lab values. And I was chatting with a 20-year experienced hospice nurse who said they were trained to go by the numbers. And internally, between me and you, my head is exploding because I need to be blunt. That is wrong on so many levels. First and foremost, hospice is about the individual person before us. And we're there for the caregivers and the family members. I do want to give a shout out to Shelley Henry and Adam, her husband, of the Amity Group, because they continue to promote hospice and palliative care. And they will be among the first to share, and I'm there with them. Caregivers matter. Caregivers matter. But when it comes to the patient, they're a human being, an individual, and we are never there to treat the numbers. We're there to treat the person. Not saying numbers never matter, but in the grand scheme of things, the vital signs and the lab values are about that smaller. I cannot tell you enough how that is important. And I had the wonderful opportunity to be gifted this book, Nursing Intuition, How to Trust Your Gut, Save Your Sanity, and Survive Your Nursing Career by Jennifer A. Johnson, RN. I was gifted this book. Jennifer actually uh, signed it as I participated in the Nursing Summit. And I was so grateful for her for sending me this book. Um, so here, I do want to go into this a little bit. Um, page 17, she goes over different stories in her book that are case studies. And what got me is just in the very first chapter, page 17, 18, 19, 20, and 21 was the first case study. And the whole entirety of it is she felt something was completely wrong. And the vital signs were painting a completely different picture, as if everything was okay or would be getting better. And the patient died. Let that sink in. She learned a lesson that she should have trusted her nursing intuition instead of the lab values, instead of the vital signs. And that has been the overwhelming bulk of my nursing career, is learning to trust your gut. Learning that if your nursing instinct is telling you that the doctor told you they have 3 to 6 months, but your nursing instinct as a hospice nurse is they don't have more than a few days to a week or two, trust your instincts. Increase the nursing visits. Interview and explore more. I cannot emphasize enough of open-ended questions and active listening. If the patient and the family's telling you something does not seem right, I don't know how to explain it. There's different ways that a patient may share impending doom. Just feel dread. I don't know what it is. I'm more nervous, I'm more scared. And you have, sometimes they're not going to come out and roll out of their mouth, so to speak, what I just said. You have to explore, you have to have a curious mind. So in terms of coming to a close for this video, in terms of trusting your gut, this is a shorter video, at least my hope. No offense. Um, Ask questions, explore, focus on what they are saying are symptoms that matter to them. Let me give you a case I had with one of my patients in terms of, if you're looking at what about if we just go with the hospice philosophy? Hospice philosophy is comfort. If they're not complaining about it, don't treat it. That's the overall hospice philosophy. If they don't complain, if the patient is not complaining about it, don't treat it. Had a patient in a facility. I did the admission and I was the case manager. So I was seeing this patient. I was the main nurse seeing, and it was very consistent. I do my best when I am the case manager to not be pushed aside when I can't. Sometimes management redirects and you don't have a choice. Uh, but this patient always had a very low grade, no, I'm sorry, wrong patient. They were always low, it was low, I was thinking low grade, but I went fever, but it was low grade tachycardia. I don't know if there's such a way to word it, but they were around 102 to 105. They came on for protein, calorie malnutrition, so they're losing weight. And if they're not eating, they're most likely not drinking as well, and especially with our elderly or geriatric patients. So I'm chalking this up initially to dehydration. How are we going to treat dehydration? We don't give IV fluids in hospice. And as I'm sharing this with you, I know there might be family members. Well, what do you mean they're starving and dehydrating to death? No, rabbit trail. Forewarning, rabbit trail. Our bodies, in the best case, need to be as dry as a dry sponge, as close to death, to avoid lingering through the active dying process where people are saying, why are they taking 2 or 3 weeks in a comatose-like state? The more dehydrated somebody is, the closer they are to death, the better. And our body, I thank you, Dr. Eric Barr, who taught me at a Saracare hospice when it was under Golden Living. They're now owned by Abenesis, unless they've changed hands. It's been a while since I worked there. But, the brain shuts down the drive to eat and drink. The closer we are to death, starvation is a feeling, so they're not having the feeling. Anyway, so I took it, they're just natural dehydration. We don't do IV fluids in hospice. So we're not going to treat this. There's no complaints from the tachycardia. But it just didn't sit right with me. And the more I went, it just didn't sit right with me. The first couple times it didn't sit right with me. I'm being transparent with you. I didn't do anything differently. It just was that nagging feeling. And everything from a prognosis standpoint, and I consider myself above average with this. Some might say master from a point of view. I've written a book, The Art of Hospice Prognosis. I'm mastering hospice eligibility. The God willing, I'm going to be doing a keynote speech in March in South Carolina to an interdisciplinary conference, the first nurse ever to be the primary keynote speaker. And I'm still in awe, like, how did I get picked out of everybody else in the world? I don't know. I'm thankful, but it's like I'm still like, wow. There's a lot of people far better, more experienced than me, but I'm not complaining, nor am I turning down the opportunity. But the first couple of times it was like just nagging. But then the prognosis to me, based on everything else, the BMI, the weight loss wasn't that drastic. Protein cow malnutrition is not my favorite diagnosis. It is too easy to come on hospice and too easy to come off of hospice with PCM. Not my favorite diagnosis. And there were no other underlying health issues. But something was nagging at me. So I said to myself, Would it be possible that this person is far closer to death than all other indicators? And I said to myself, I need to come more often. And I have a book, The Art of Hospice Visit Planning. Yes, me and my books. I'm a book author. But part of why I wrote so many for all the different genres, hospice, caregiving, holistic health, end-of-life practitioners in general, mainly doulas, is because they're very targeted, specific topics. And so I increased the visit frequency. And what I started to see, because I increased the visit frequency, because I started trusting my gut, is this person was transitioning. I want to caution, especially my new hospice nurses, transitioning in the early stages can be very much like a rally, a rally that when I say mystical, I'm not talking about new age or something like rolling the dice or magical. We just don't properly, with all the studies that have been done, don't properly understand the rally at end of life. The rally normally happens during the transitioning phase. The dying is two parts for anyone new watching. Dying is two phases. You have the transitioning phase that can last seconds. So it's like, where did it go? To I've had it last 4 weeks. I've had colleagues say they've seen 6, which I've never. 6 is kind of hard to believe, but I don't want to doubt them. They got their license. So seconds to 4 to 6 weeks. The average is about 2 to 3. And then you have active dying. Active dying, the overwhelming 99% of the time, the person's in the equivalent of a coma. They're asleep, they cannot be woken. I've had a handful of cases where they're wide awake and actively dying, and able to, and struggling to talk, but they're actively dying. That's very rare. It does happen. But that transitioning stage in the very early beginning, before brain disconnect, the rally happens in the transitioning phase. Typically, it's in the latter part of the transitioning phase. And if the rally happens, doesn't always happen, active dying typically starts in 72 hours or less. And if it's a powerful rally, active dying is typically in 24 hours and less. And those who have the biggest rallies ever, their active dying is typically short. Instead of being, seconds to, I still remember my one active dying December 23rd of 2018 to January 9th of 2019. They both the admitting nurse, case manager, and pronouncing nurse. Wow. Um, so in the transitioning phase, the rallies sometimes are missed because they can happen while people are sleeping. They can happen when people are out of the room. Sometimes they're brief. Sometimes they're 15 minutes to an hour. And if you are not there in person, you miss it. So by increasing the frequency, by being there more often, by saying, okay, this low end tachycardia, 102, 105, 106, it was always in the low 100s. I caught that they were transitioning. They were closer to dying than I had originally prognosed. And when I caught that they were transitioning, I put them to daily visits, 7 days a week, so that they can get more support, that I can update the family more. I caught they were transitioning, I'm updating the family. So where we're ending, and I do thank you so much for your time, where we're ending, it's whether you're new or old, and I don't mean age necessarily, as a hospice nurse. We treat the person, not the numbers. And while in this case I am mentioning a vital sign, it's more about the instinct. It's more about asking yourself, what else could be this tied to? There's more than meets the eye. Trust your instincts. So in the links below, I'm going to put a link to this book on Amazon. I'm going to put a link to some of my books that I mentioned. If you have any questions, any concerns, maybe you have a different point of view, this is a non-judgmental channel, comment, let's have a discussion. If you want to reach out to me via email, check the channel description. My email's in there. Let's have a conversation. I don't mind collaborating, brainstorming. Let's all bloom together. Thank you. God bless, and bye.